Hello students, welcome you all in the part 2 for antidepressant drugs. Here we are discussing about the tricyclic antidepressants drug. These drugs in this category we will take imipramine as a prototype drug, and we can say that imipramine is an analog of chlorpromazine, which comes under the category of phenothiazine. It inhibited noradrenaline 5-HT reuptake into neurons. It inhibits noradrenaline and 5-HT reuptake into neurons. Here you see these drugs are not acting on the metabolism or not saving the drug these noradrenaline sorry by metabolism, but they are using the different pathway. They are inhibiting the reuptake of it. Already in noradrenaline synthesis and release topic, I have discussed about the reuptake mechanisms. The tricyclic antidepressants are no longer considered first-line agents in the treatment of depression because of their prominent side effects and the need to monitor drug blood level to avoid toxicity. This is the structure of imipramine. We have the three-ring structure. Now we'll see how these tricyclic antidepressants, especially imipramine, acts. The tricyclic antidepressants inhibit monoamine reuptake and interact with a variety of receptors. For example, muscarinic, adrenergic, histamine, where you have H1, 5-HT1, 5 means histamine receptors like H1, serotonin receptors like 5-HT1, 5-HT2, and occasionally dopamine D2 receptor. It means these drugs are having the possibility to interact with these variety of receptors, right? And that's why the variety of effect can be produced. TCAs and related drugs inhibit active reuptake of biogenic amine, noradrenaline, and 5-HT into their respective neurons and thus potentiate them. It means if the reuptake will not be there, then what is this consequence? These noradrenaline and 5-HT will be more in concentration at the synaptic cleft and more available for binding to the postsynaptic neuron. TCAs indirectly facilitate dopaminergic transmission in forebrain that may add to the mood elevating action. So here also facilitating dopaminergic transmission, right? Also make it dopamine more available for its action, and that will help out. You know, the role of dopamine is in the mood, so it will help out to mood elevation. Adrenoceptor downregulation at central adrenergic synapse is one popular theory. Here, little deviate. I'll take you little deviated from this and take you to the another receptors, how it works here. So this is one more theory. What happened? The downregulation at central noradrenergic synapse is one popular theory used to explain the antidepressant property of TCA's drug. This theory focuses on a cascade of adaptive changes at the noradrenergic synapse that appears to be triggered by inhibition of norepinephrine neuronal reuptake of TCA's drug. However, at noradrenergic synapses with multiple adrenoreceptors, synaptic transmission through one adrenoceptor will likely to be enhanced at the same time that synaptic transmission through second and adrenoceptors is reduced. So like that, it is reducing or down regulating the adrenoceptor communication pathway. I would like to give you one flow chart here which can help you out better. This is the cascade of adaptive changes occurring at the norepinephrine. You can see inhibition of nerve terminal, norepinephrine neuronal uptake system. Then what happens? Increases in synaptic concentration of noradrenaline. then it desensitizes the nerve terminal alpha-2 adrenoceptors. You might be remember what the alpha-2 does. Increases in neuronal noradrenaline release. You know, alpha-2 adrenoceptors, known as the autoreceptors, or they do the uptake. They are prejunctional receptors, right? Presynaptic receptors. And when you are blocking this or desensitizing this, the uptake will not be there. Then more amount of noradrenaline will be there. Further increase in synaptic concentration of noradrenaline, desensitization of postsynaptic beta adrenoceptors, and this way higher activity of noradrenaline will cause the beta adrenoceptors on postsynapse desensitized. But there will be no change in postsynaptic alpha-1 adrenoceptor sensitivity. So alpha-1 effects will be carried on as such, but beta effects will be desensitized or inhibited. This is one of the mechanism. Here you can see this diagram will explain you very well that how it's happening. You can see this is noradrenaline, right? This noradrenaline is usually it is going in or auto taken by the taken in, and if you give the tricyclic antidepressants here, they inhibit the binding of noradrenaline to the alpha-2. You can see the alpha-2. When the alpha-2, because noradrenaline will be taken back by the autoreceptors here and here back into the nerve terminal, and that reuptake will be blocked by the tricyclic antidepressants here. Okay. In case of desensitization of beta receptor, as I told you here, the desensitization of beta receptor is also there here, but alpha effects has no issue. Alpha has no problem, right? Alpha-1 binding is as such. So like that, if you give tricyclic antidepressant, they inhibit the reuptake by alpha-2 receptors as well as desensitize the beta receptors, but alpha-1 effect will be the same. But if you come back to the 5-HT, here also the similar thing is happening. 5-HT has been taken back by 5-HT1A receptor, which has been blocked by the tricyclic antidepressants here. And here you see the 5-HT1A and 5-HT1A here, means they get also desensitized. So like that, these drugs are playing the role here. Okay, so reuptake inhibition results in increased concentration of the amines in the synaptic cleft in the CNS and periphery. Inhibition of dopamine uptake correlates with stimulant action but is not primarily involved in antidepressant action. Inhibition of noradrenaline and 5-HT uptake is associated with antidepressant action. So as we have discussed in beginning itself, that main target is the noradrenaline and 5-HT uptake. Okay. Initially, the presynaptic alpha-2 and 5-HT1 autoreceptors are activated by the increased amount of noradrenaline and 5-HT in the synaptic cleft, resulting in decreased firing of locus coeruleus at the noradrenergic and raphe serotonergic neurons. However, on long-term administration, antidepressant desensitize presynaptic alpha-2, what I have already explained you in the diagram, 5-HT1 and 5-HT1D. Means if you are using these drugs for even longer period, then there is a chance that alpha-2 can also get desensitized. Autoreceptors and induce amine turnover of brain, the net effect of which is enhanced noradrenergic and serotonergic transmission. Okay, so this is about the mechanism, how the tricyclic antidepressants work. Now we'll see pharmacological actions of these drugs. First, we'll see CNS effect. Here, when we observe the CNS effect, sometimes what happens, diagnosis usually is based on the symptoms. For the depression, diagnosis is based on the symptoms. Psychiatrists or the uh, uh, doctors, they'll ask lot many questions to these depressive patients, and on the basis of the answers, they will conclude that the symptoms are related to the depression. So sometimes these diagnoses may not be exactly correct, right? Maybe it's all the momentary symptoms have been considered. So in that basis, its chances are quite high that we are treating a normal person. So it is very important to understand the effect of these drugs on CNS for the normal as well as depressed patients. First, we'll see what happens to the normal individual. It induces a peculiar clumsy feeling, tiredness, lightheadedness, sleepiness, difficulty in concentrating and thinking, unsteady gait. Gait means walk. These effects tend to provoke anxiety. Now, what is happening? A normal person will be the patient of anxiety. There is no mood elevation or euphoria. Effects are rather unpleasant and may become more so on repeated administration. Now we'll see what is happening to the depressed patient. Little acute effects are produced except sedation. After 2 to 3 weeks of continuous treatment, the mood is gradually elevated. Patient become more communicative and start taking interest in self and surrounding. REM sleep phase is suppressed and awakening during night are reduced. The EEG effects of low dose are similar to hypnotics, but high doses causes desynchronization. The TCAs lower seizure threshold. TCAs lower the seizure threshold, right? And produces convulsions in overdose. Clomipramine, meprotilene, and bupropion have the highest seizure precipitating potential. Amitriptyline and imipramine depresses respiration in overdose. Trimipramine is weak noradrenaline 5-HT reuptake blocker, but an equally effective antidepressant. None of these compounds except amoxicillin and to some extent meprotilene blocks dopamine receptors or possess antipsychotic activity. Now we'll see the effect of TCAs or imipramine on ANS. Most TCAs are potent anticholinergics. So when they are anticholinergics, now you can assume all the anticholinergic side effects can be appear. Dry mouth, blurring vision, constipation, urinary hesitancy, these are some side effects of it. Now we'll see the effect on CVS. Arrhythmias occur in overdose due to interference with intraventricular conduction. Combination of noradrenaline potentiating plus ACH blocking actions and direct myocardial depression. Tachycardia has also been observed due to the anticholinergics and noradrenaline potentiating action. In overdose, it has become very serious. For older patients are not susceptible. Postural hypertension due to inhibition of cardiovascular reflexes and alpha 1 blockage, that's also been observed. ECG changes and cardiac arrhythmias, as already discussed. What happened in there? T wave suppression or inversion. If you see the ECG of that particular patient who has taken this drug, you can find the T wave suppression or inversion. Now we'll discuss about the tolerance and dependence and some pharmacokinetic details of these drugs. They are potent cholinergic muscarinic receptor antagonist, resulting in symptoms such as dry mouth, bad taste, constipation, epigastric distress, urinary retention, blurred vision, palpitation, etc. Sedation, mental confusion and weakness, especially with the amitriptyline. Blockage of histamine receptor often results in sedation and weight gain. Antagonism of adrenoceptors in the vasculature can cause orthostatic hypotension. TCAs drugs have potent membrane stabilizing properties similar to those of quinidine. You remember quinidine. Conduction is lowered throughout the heart and serious ventricular arrhythmias can be caused. It means any patient, any person who is already having certain cardiovascular disorders, especially arrhythmia or fibrillation or any kind of conduction related disorders, this drug is not very suitable for them. Amoxicillin has dopamine receptor antagonist properties and can induce extrapyramidal side effects, gynecomastia, lactation, and neuroleptic malignant syndrome. Some patients showing the mania as well. Sweating and fine tremors can also appear. Increased appetite and weight gain also observed in some TCAs, for example, trazodone. Some rashes and jaundice can also be observed. TCAs potentiate, now we'll see some drug interaction about the TCAs. Very important, as I told you, for all the classes, drug interaction is very important. TCAs potentiate directly acting sympathomimetic amines. Where are these drugs? These are drugs usually used in the case of cold remedies and asthma remedies. TCAs abolish the antihypertensive action of guanethidine and clonidine by preventing their transport into adrenergic neurons. TCAs potentiate CNS depressants, including alcohol and antihistaminics. So always very much cautious to use alcohol and antihistaminic or antiallergic drugs along with this. Phenytoin, phenylbutazone, aspirin and CPZ can displace TCAs from protein binding sites and causes toxicity. You know, whenever the protein binding displacement happens, the more amount of drug is available in the system, and that can cause, that will accumulate and cause the toxicity. Phenobarbital induces as well as competitively inhibits imipramine metabolism. So it induces or inhibits the metabolism of the drug. So that's why phenobarbital and imipramine combination can be less efficacious. Carbamazepine and other enzyme inducers enhances metabolism of TCAs. When metabolism increases means the effectiveness of the drug, the duration of effect and all will decrease. SSRI inhibit metabolism of several drugs including TCAs. Dangerous toxicity can occur if the two are given concurrently. So another thing is the two classes here, SSRI, which is again a very important class for antidepressant, and TCAs again very important class of antidepressant, but cannot combine together because of this condition. MAO inhibitors, dangerous hypertensive crisis with excitement and hallucinations has occurred when given with TCAs. Now another problem is that the first class which we have discussed about MAO inhibitors, here we cannot combine with this drug. Okay, so I hope you understood about the pharmacology of TCAs. Now we'll discuss about the next class, that is the very important class here, serotonin, selective serotonin reuptake inhibitors, SSRIs. Why we want SSRIs when we already have these many classes, these many big classes of antidepressant drugs? So reason is here, to overcome the shortcomings of TCAs and other antidepressants, the SSRIs developed. So it means SSRIs are better than those which are earlier discovered and used, like TCAs and other drugs. Let's see why. The major limitations are frequent anticholinergic, cardiovascular and neuronal side effects. These are the limitations I am talking about, the TCAs and other antidepressants. So when we discovered SSRIs, SSRIs are they are improving all these things. Frequent anticholinergic, cardiovascular and neurological side effects, relatively low safety margin. So these drugs are having low safety margins, means TCAs and other drugs. Hazardous in overdose. Fatality is common. Lag time of 2 to 4 weeks before antidepressant effect. Significant number of patients respond incompletely and some do not respond. The most significant of these are the SSRIs, which selectively inhibit membrane associated SERT, but TCA's overall efficacy is higher than any of the new drugs. See, when we talk about the efficacy, TCA's efficacy is incomparable, but safety is better with the SSRIs. More importantly, the newer drugs have improved tolerability, both in therapeutic use as well as in overdose. It has been claimed that certain drugs, say bupropion, venlafaxine, mirtazapine, have faster onset of antidepressant action. The relative safety and better acceptability of SSRIs has made them first-line drugs in depression and allowed their extensive use in anxiety, phobias, OCD, and related disorders. So SSRIs are not only used in antidepressant, but the larger group of disorders. It's also effectiveness has been observed in anxiety, in case of phobias, in OCD, obsessive compulsive disorders, and related disorders. The SSRIs produce little or no sedation, do not interfere with cognitive and psychomotor functions, or produce anticholinergic side effects. These are very important benefits what we are getting through SSRIs. They are devoid of adrenergic blocking action, postural hypotension. Again, very important feature of the SSRIs. They have practically no seizure precipitating property and do not inhibit cardiac conduction overdose. Arrhythmias are not a problem. So even this serious problem of arrhythmia can be resolved by using SSRIs. But even though having a high range of safety, it has some very serious ADRs as well. For example, prominent side effects are GI side effects. So how it affects the GI system? All SSRIs frequently produces nausea. Why? Because of the 5-HT3 receptor stimulation in the brain. But tolerance develops over time. Weight gain is not a problem with SSRIs, but they are more commonly interfere with ejaculation or orgasm. A new constellation of mild side effects, example nervousness, restlessness, insomnia, anorexia, dyskinesia, headache and diarrhea is associated with them. But patient acceptability is very, very good. Increased incidence of epistaxis and ecchymosis has been reported, probably due to impairment of platelet functions. Gastric blood loss due to NSAIDs may be increased by SSRIs. We'll see pharmacokinetic and some interactions here. Very, very important drug for the interactions, and usually these interactions are pharmacokinetic interactions, so we have to understand the pharmacokinetic of the drug as well. The SSRIs inhibit drug metabolism as isoenzyme CYP2D6 and CYP3A4. Elevate plasma level of TCAs, because these are the metabolizing enzyme and these drugs are inhibiting it. So if they are inhibiting it, the metabolism will be less and the amount of drug will be more for a long time, and that may cause toxicity. So elevate plasma level of TCAs, haloperidol, clozapine, terfenadine, estimizole, warfarin, beta blockers, some benzodiazepines and carbamazepine. Serotonin syndrome manifesting as agitation, restlessness, sweating, twitching followed by convulsions can be precipitated when any serotonergic drug is taken by a patient who is receiving SSRIs. Some degree of tolerance to antidepressant action of SSRIs has been noted in few patients after months of use. The overall antidepressant efficacy of SSRIs is similar to that of TCAs, though some patients not responding to one may respond to other. So SSRIs and TCAs, I told you, very important class of antidepressant drugs. So when some patients are not responding to TCAs, they switch to SSRIs, or when they are not responding to SSRIs, they switch to TCAs. In severe depression, however, TCAs appear to be more efficacious. So that's what on the efficacy level, TCAs are better than the SSRIs, but on safety level, SSRIs are better than TCAs. Now we'll see some important uses of this class of drug. Number one, endogenous depression, which we call it as major depression. The aim is to relieve symptoms of depression and restore normal social behavior. Choice of a particular drug for an individual patient depends on secondary properties. Which are secondary properties? Sedative, anticholinergic, hypotensive, cardiotoxic, seizure, and precipitating actions. So on that basis, we select the drug. Effective in juvenile depression are fluoxetine and sertraline. Moclobemide is a better tolerated option for mild to moderate depression, especially suited for elderly and cardiac patients. After a depressive episode has been controlled, continued treatment at maintenance dose. Right, when the depressive episode get over, then continue treatment with the maintenance doses, where 100 mg imipramine per day can be given. It can be given for months, and it is better to give it to prevent the relapses. Therapy is generally not continued beyond 1 year. Combination of SSRI with an atypical antipsychotic such as olanzapine for its anti-manic property is also accepted, and this can be used for the bipolar depression treatment as well. Obsessive compulsive and phobic states, this is a drug of the choice. TCAs, especially clomipramine, are highly effective in OCD and panic disorders. SSRI and TCAs are reduced compulsive eating in bulimia and help patients with body dysmorphic disorder, compulsive buying, and leptomania. Please go through the dictionary to find out all the terms and their meaning. Next is use in the anxiety disorders. Antidepressants, especially SSRIs, exert a delayed but sustained beneficial effect in many patients of generalized anxiety disorder. May be used along with short course of benzodiazepine to cover exacerbation. SSRI have also proven helpful in post-traumatic stress disorders. Neuropathic pain. Imipramine affords considerable relief in diabetic and some other type of chronic pain. Amitriptyline reduces intensity of post-herpetic neuralgia in 50% of patients. Attention deficit is another condition. Hyperactivity disorder in children. TCAs with less depressant properties like imipramine, nortriptyline, and amoxicillin are now first-line drugs for this particular treatment. In neuresis, in children have 5 years, imipramine 25 mg at bedtime is effective, but bedwetting may again start when the drug is stopped. Elderly subjects with bedwetting have also benefited with this disease, with this drug. Next is migraine. Amitriptyline has some prophylactic value, especially in patients with mixed headaches. Pruritus. Some tricyclics have anti-pruritic action. Topical doxepin has been used to relieve itching in atopic dermatitis and lichen simplex, etc. Okay, so by this you have understood two very important class here, TCAs and the SSRIs. Please go through these slides and understand well the mechanism, and because there is a lot of chance that you may confuse with the mechanisms, so that you have to be understood clearly. Now you have to understand or prepare about certain individual drugs of these categories, what I am giving you as an assignment. So please prepare the pharmacology of amitriptyline, desipramine, fluoxetine and trazodone, and also prepare one note on the treatment of depression. Here are the references. You can find some pathological points I have taken from Robbins, some clinical part I have taken from DiPiro. Pharmacology has been taken from Rangendale, Harvey, Richard, Goodman Gilman, K.D. Tripathi, Katzung, and very important, Charles R. Craig Robert is Sizzle Modern Pharmacology of Clinical Applications. Thank you all for listening this video carefully. Thank you.